Antihypertensive drugs. It is important to understand a few pharmacokinetic terms that help describe how drugs behave in the body. Bioavailability refers to the percentage of a drug that reaches systemic circulation after administration. Onset is the time it takes for the drug to start working, while duration indicates how long the therapeutic effect lasts. Peak plasma time, or Tmax, refers to the time taken for the drug to reach its maximum concentration in the blood. Protein binding describes the portion of drug attached to plasma proteins, which is temporarily inactive. Finally, volume of distribution represents the extent to which a drug spreads throughout body tissues. Metabolism is the chemical conversion of a drug into metabolites, usually occurring in the liver. Some metabolites remain active and continue producing therapeutic effects, while others become inactive. Half-life refers to the time required for the plasma drug concentration to decrease by 50%. Dialysability indicates whether a drug can be removed from the body through dialysis. Another important term is AUC, or area under the curve, which reflects the total drug exposure over time. Finally, excretion is the removal of drugs or metabolites from the body, usually through the kidneys. ACE inhibitors are a commonly used class of antihypertensive drugs. Examples include lisinopril, ramipril, enalapril, captopril, and perindopril. These drugs work by blocking the conversion of angiotensin 1 into angiotensin 2, which is a powerful vasoconstrictor. By preventing the formation of angiotensin 2, ACE inhibitors cause vasodilation, reduced aldosterone secretion, and decreased blood pressure. Common side effects include dry cough, dizziness, hyperkalemia, and first-dose hypotension. They are widely used in hypertension, heart failure, and diabetic nephropathy. This table represents the major pharmacokinetic parameters: absorption, distribution, metabolism, and elimination. Absorption, how the drug enters the bloodstream. Distribution, how the drug spreads in the body. Metabolism, how the drug is processed in the liver. Elimination, how the drug leaves the body. Most of these drugs start working within about 1 hour. Some, such as ramipril and enalapril, are prodrugs activated in the liver, while others like lisinopril are already active. Most ACE inhibitors are eliminated through the kidneys. Another important class is angiotensin receptor blockers, or ARBs. Examples include losartan, telmisartan, valsartan, irbesartan, and olmesartan. Instead of blocking ACE, these drugs block the angiotensin 2 receptor, preventing vasoconstriction and reducing blood pressure. ARBs are often prescribed when patients cannot tolerate ACE inhibitors due to persistent cough. Important side effects include hypotension, hyperkalemia, and renal impairment. This table compares ARBs, including losartan, telmisartan, valsartan, irbesartan, and olmesartan. These drugs generally have high protein binding and long durations of action, which allows once-daily dosing. Losartan is unique because it forms a very potent active metabolite. Diuretics are another major group used in hypertension management. They work by increasing the excretion of sodium and water through the kidneys, which reduces blood volume and lowers blood pressure. There are 3 main types: loop diuretics, such as furosemide and bumetanide; thiazide diuretics, such as indapamide and hydrochlorothiazide; potassium-sparing diuretics, such as amiloride and spironolactone. Common side effects include hypovolemia and metabolic alkalosis. This box shows the pharmacokinetic characteristics of different diuretics. Loop diuretics like furosemide act quickly, especially when given intravenously. Thiazide diuretics, such as hydrochlorothiazide, have longer duration and are commonly used for hypertension treatment. Calcium channel blockers reduce blood pressure by blocking calcium entry into cardiac and vascular smooth muscle cells. Since calcium is required for muscle contraction, blocking it results in vasodilation and reduced cardiac workload. Examples include amlodipine, nifedipine, verapamil, and diltiazem. They are classified into 2 groups: dihydropyridines, such as amlodipine and nifedipine, which mainly affect blood vessels; non-dihydropyridines, such as verapamil and diltiazem, which also affect heart rate. Common side effects include ankle swelling, headache, flushing, and palpitations. This table summarizes calcium channel blockers, such as amlodipine, nifedipine, verapamil, and diltiazem. Amlodipine has a particularly long half-life, allowing once-daily dosing. These drugs are mainly metabolized in the liver. Beta blockers reduce blood pressure by blocking beta-adrenergic receptors, which decreases heart rate and cardiac output. They can be classified as selective beta-1 blockers such as atenolol and metoprolol, non-selective blockers such as propranolol, mixed alpha and beta blockers such as labetalol and carvedilol. Beta blockers work by blocking beta-adrenergic receptors, beta-1 and beta-2, that normally respond to epinephrine and norepinephrine. Blocking beta-1 receptors in the heart decreases heart rate, contractility, and renin release, which lowers cardiac output. Overall, this leads to reduced blood pressure and decreased oxygen demand of the heart. Common side effects include fatigue, cold extremities, nausea, and headache. This box compares different beta blockers including atenolol, metoprolol, propranolol, labetalol, and carvedilol. Some drugs like metoprolol are metabolized in the liver, while atenolol is primarily eliminated through the kidneys. Alpha blockers work by blocking alpha-1 receptors in blood vessels, causing vasodilation and lowering blood pressure. Blocking alpha-2 receptors can increase norepinephrine release, which may cause reflex tachycardia. They also relax smooth muscles in the prostate and bladder, improving urine flow in patients with prostate enlargement. Examples include tamsulosin, doxazosin, alfuzosin, and prazosin. One important side effect is postural hypotension, which may lead to dizziness or fainting, especially after the first dose. This table summarizes the pharmacokinetic properties of alpha blockers, such as tamsulosin, alfuzosin, phentolamine, and prazosin. These drugs work by blocking alpha-1 receptors in blood vessels, leading to vasodilation and reduced blood pressure. Most of these drugs are metabolized in the liver and excreted through urine or feces. Alpha-2 adrenergic receptor activation reduces norepinephrine release from nerve endings, which decreases sympathetic activity. This leads to lower heart rate and blood pressure, along with sedation and analgesia in the central nervous system. Overall, alpha-2 agonists like clonidine produce sympatholytic effects that help control hypertension. Examples include clonidine, methyldopa, and moxonidine. These drugs lower blood pressure by reducing the release of norepinephrine. Common side effects include dry mouth, sedation, fatigue, and rebound hypertension if the drug is suddenly discontinued. This table shows the pharmacokinetics of alpha-2 agonists such as clonidine and methyldopa. These drugs reduce blood pressure by decreasing sympathetic nervous system activity. Clonidine has relatively good bioavailability and a half-life of around 12 to 16 hours. Common side effects include dry mouth, fatigue, and sedation, and sudden discontinuation may lead to rebound hypertension. Renin inhibitors represent another class of antihypertensive drugs. The main example is aliskiren. This drug works by directly inhibiting renin, preventing the formation of angiotensin 1 and angiotensin 2. As a result, blood pressure decreases. However, renin inhibitors are rarely used in clinical practice. Possible side effects include hyperkalemia, hypotension, diarrhea, and angioedema. It has low bioavailability, but a long half-life of about 24 hours, allowing once-daily dosing. It is mainly metabolized by CYP3A4 and eliminated through bile and urine. Sodium nitroprusside acts as a nitric oxide donor. When it enters the blood, it releases nitric oxide, which activates the enzyme guanylate cyclase in vascular smooth muscle. This increases cGMP levels inside the cell, which lowers intracellular calcium and causes relaxation of vascular smooth muscle. As a result, blood vessels dilate, peripheral resistance decreases, and blood pressure falls rapidly. Hydralazine mainly causes dilation of arterioles by reducing intracellular calcium in vascular smooth muscle cells. It opens potassium channels and reduces calcium entry into the cells, which leads to smooth muscle relaxation and vasodilation. This decreases peripheral resistance and blood pressure, although it may trigger reflex sympathetic activity that increases heart rate. Examples include hydralazine and sodium nitroprusside. Hydralazine is often used in resistant hypertension, while sodium nitroprusside is mainly used in hypertensive emergencies due to its very rapid onset of action. Possible side effects include tachycardia, flushing, headache, and severe hypotension. Hydralazine has a moderate onset and hepatic metabolism, while sodium nitroprusside acts very rapidly and is used in hypertensive emergencies. Their metabolites are mainly excreted through the urine, and important side effects include tachycardia and hypotension. This slide provides a quick summary of the major classes of antihypertensive drugs and their pharmacokinetic characteristics, including bioavailability, onset, peak time, duration, metabolism, and elimination. It helps compare the different drug classes and serves as a useful revision tool.